What we were interested in was understanding from a kind of international perspective what features of integrated care are the most appropriate for improving quality of care and system sustainability for people with chronic conditions. Now, we particularly focused on seniors, but seniors are only one population that need continuing care. Other groups would be children with disabilities, adults with disabilities, and people with mental illnesses. So basically anyone with a chronic long-standing condition could benefit from an improved coordination of care and what often is termed seamless delivery of care, although one could question how frequently we achieve seamlessness. We identified 4 frameworks, but by far the most comprehensive of those was a framework developed here in Canada by Marcus Hollander and Michael Prince out of Victoria. And their framework was published in Healthcare Papers last year, but was developed in 2008, but was developed originally in 2001 on the basis of 250 interviews they did with senior policymakers from across Canada. We found, however, that frameworks developed from other countries were very similar to the Hollander and Prince framework, but we liked it, Hollander and Prince, because it was much more comprehensive than other frameworks. The framework includes several specific sections. The first one is a set of policy and philosophical and values-based prerequisites that drive how a governmental entity might, or even a group of providers, might approach improving care for seniors with chronic conditions. They're values-based. In other words, are they client-centered? Do they respect the input of families and seniors themselves? Are they based in notions of equity and comprehensiveness of care and those kinds of things? The second feature is there are 2 major sections next. The first one is administrative best practices. So what are the kinds of administrative or infrastructure ingredients you should have in improving care for people with chronic conditions? So those include such features as integrated information systems. They include incentives for using resources most effectively. They include incentives for using evidence-based information and other kinds of structural ingredients such as that. The next area is the clinical area, and that's the area where you see the use of interdisciplinary care management teams, uniform assessment and care planning documents, system-level classification systems, communication systems with families. Those are the areas which actually interact directly with the client population and the system. And then there are what is called sort of boundary spanning or linkage mechanisms. So we have a home and community-based care system for people with chronic conditions, but that care system has to link with such major entities as hospitals, primary care physicians, other health and social service providers such as transportation providers or housing providers, and other organizations that are looking after other population groups. So the model is comprehensive, it's well laid out, and it was the model that we chose to use to guide the next stages of our work.